thank you all for inviting me here. And I think most of you know I'm Jared Gardner, and I'm a pathologist from the U.S. And I deal with DFSP and other types of sarcoma. And I wanted to just say a few words and then answer some questions if any of you had. And then also I think some people from the group had submitted some questions. So I thought that would be good to do. But I wanted to start with telling kind of a little bit of my story and how I got involved in this group. So 2.5 years ago, I joined this group and introduced myself as a pathologist. And at that time I wasn't sure, am I allowed to be in a patient group? Is this normal? No one else in my specialty is doing this. And Pip very kindly welcomed me to the group and said, yes, of course you're welcome to be here. We would love to have you here. And it was really that interaction right there and me joining this group that really kind of changed the course of my career, and it started me off on the path of being involved in, I'm in a dozen different sarcoma patient groups now, and now I give talks to doctors all the time, to other pathologists, about why this is important and why we should be doing this as a specialty, because I have the opportunity to answer questions about this disease that I know about that you might not be able to ask your surgeon or your oncologist. So I think that there are a lot of people in my specialty that have that kind of knowledge about a variety of different rare diseases, and if every patient group had a pathologist there to answer some questions and help educate them, I think it would benefit everyone involved. And it's not just about that, but I've actually learned an enormous amount from all of you, and I mean, quite frankly, I've seen 75 to 100 cases of DFSP now, but there are 1,000 patients in this group. And the stories that all of you share, and the stories of how you were misdiagnosed clinically, how almost all of you were thought to have a cyst clinically, that's changed the way that I practice medicine. It's changed the way that I treat my own patients. It makes me more cautious when I diagnose DFSP. I teach my medical students every single year about DFSP. 170 future doctors all heard of DFSP every single year because of all of you, because of this group. I wouldn't be teaching them about this otherwise. I would have thought this is esoteric, they don't need to know about it. But they do need to know, not because this is a common cancer, but because there are a lot of other cancers that are just like this, that start out looking like a little bump, like a little cyst. And if you're not thinking about that stuff, if you're not realizing, hey, cancer sometimes looks like this, then it's going to get missed. And so I want them to go out into practice and know that, hey, there are rare things, and if you don't know what something is, get a biopsy. Don't just blow it off and ignore it. So that's your group that's done that. That's why I do this, because of all of you. Because the stories that you've all told me have an impact in the way that I view this disease and the way I practice medicine. So it's really wonderful, and I think you guys, you owe yourselves, a huge round of applause for that. You really have done something that's really big, and I'm trying to carry that forward and share that story with other doctors I work with and with my students. So that's kind of how I got involved. And then I think 6 months or so, a few months after I joined the group, someone asked me a question. One of the patients, who I think is not even involved actively anymore, but he said, well, what about fibrosarcomatous DFSP, the kind of higher grade form? Is it worse or is it not worse? Some people say it is. And I said, well, there's conflicting data. The literature, some of the studies say, yes, it's a higher risk of spreading to other parts of your body and being more aggressive, and other studies say, no, it's not. But we don't have any really big studies. And he said, well, there's like 600 of us in this group. Why don't you study us? And I thought, that's a pretty good idea. What is my internal review board, my ethics board, going to say when I tell them I want to do a Facebook research project? So when I give this talk to the pathologists, they all laugh because they know how crazy that sounds to use Facebook to do medical research. But seriously, have any of your doctors have 600 or 1,000 DFSP patients I've seen? No. Even the biggest cancer centers in the world can't pull together this many patients this quickly and this easily, like this group has done. So what you've done, Pip, by making this group is really made this huge, powerful resource and this powerful group of patients that can lobby together to change the way education's done, to change the way research is done, to make things different. And that's what you all want, right? Wouldn't you all wish that someone would have done this 10 years before you got diagnosed? Yeah. Right? So I know that doesn't change things for any of you, but hopefully in 10 years it will change the way that future patients get handled. And hopefully it will be better for them than it was for all of you. And maybe that's not as good as it could have been. It would have probably been better that you never had this, that you never had to deal with this. But if you had to deal with it, I'm going to do the best I can to make sure that your stories get told and that some good comes from it. So that's my job. I'm here to tell your story. And nothing that I say to other doctors means anything. It's all of the stories that I tell that from what patients have told me, that's what really hits home when I give a lecture. But right before I came on this trip, I gave a lecture to 200 doctors in Houston. Houston, Texas in the US. And I talked about pathologists being involved in Facebook patient groups. And I told the story about PIP and about the DFSP group, and then other sarcoma groups I've joined. I told stories of what the patients have told me. I told them how this is changing the way I practice and how we could all, if we were all involved, this would be so much better for everybody. And they listened, not because I was saying something that was really amazing of myself, but because I was telling them patient stories. Because at the end of the day, all of us in medicine, we may get distracted by other things. We may have other cares and concerns, but what we really care about is taking care of sick people. And when you tell a group of doctors something that a patient told me and that was impactful, they listen and they hear. So you may have stories that you're not able to tell because you're just patients. And that's sad that you're just patients, but you don't have that voice and that degree. I have the degree and the loud voice, and I talk a lot. But you guys have the story, that's really important. So I think together we make a nice team and a good partnership. And that's what I'm trying to convince the rest of the medical world of. And I got a lot of energy and a lot of enthusiasm, so I'll keep working on it. But we did put together a proposal for a study, a research project, and we started that last year. We did a small study, which actually Pip and Lee and a handful of other patients were actually partners with us and helped design the research. And they did a survey that we put out, and 200 DFSP patients took a survey in just a few weeks' time and answered all these questions. So to date, it's the biggest survey study of DFSP patients ever conducted in history. And it took 3 weeks, and all of these handful of patients helped design it, which is to me like amazing. I got goosebumps sitting there watching this video conference between Pip and people from all over the place with my residents and Pam Williams, the PhD in nursing at the University of Arkansas. We all kind of worked together to craft this survey, but it was really cool to see patients video conferencing with my pathology resident and with our other research staff making a project. It's just awesome to have patients there, and when we publish the paper, Pip's name will be there. Lee's name will be there on the paper next to mine, and I can't say there's any greater honor to me. It's really cool.
For us.
Yeah. It's pretty cool. It's meaningful, and it's really meaningful story to tell when you have that publication in literature and tell people, this is how we made this happen. We made this happen with Facebook. We made this happen with a patient group. That's a story that's powerful, and that's why we're doing this. So what's the next step? The study we did last year, we're pulling together the data, and we're actually going to present it at a large American pathology meeting next month, the American Society of Dermatopathology, which is a big organization for skin pathologists, which are people who often diagnose DFSP. So we're going to present that. Margie David, my resident, she's presenting that as a poster there at the meeting, so that'll be really cool. And we'll post a lot of information about that on Facebook and Twitter when that happens. So to kind of get the word out. And then soon after, hopefully we'll have a paper ready to be published in the actual medical literature. And in the medical world, getting something published in the peer-reviewed literature is really important, and that's how you actually get stuff out there that's believable by other doctors. So then it won't just be me talking and telling the story. Then there'll be something in the literature that says, hey, this is what this group has done, and this is the kind of information. And we found out a lot of cool things. We found out that pregnancy often causes DFSP to grow. And I had heard that from a couple patients, but when we did this survey, there was actually a lot of patients in the survey who were women of childbearing age that had DFSP that either grew or first started when they were pregnant. So this is something that's been barely mentioned at all in the medical literature, and certainly no large numbers. So we learned that just from this survey. So we learned some other very interesting things like that too. So we'll unveil all that data after we present it at the meeting. And then Pam Williams is also going to present it at a nursing meeting too, and about the whole concept of how to make a partnership between researchers and patients. Which again, to me, is just this cool, powerful idea, this patient-centered research where patients actually ask the questions that we then try to answer medically. Because who better to ask the questions than all of you, right? And that's where this kind of came from, is you came to me with questions like, well, what about this and what about that? And I said, I don't know. We don't know. Medicine doesn't know yet. So why not answer those questions, the questions that all of you want? And that's what Pip told me when I joined the group. She said, in 6 years, no other medical person, no doctor, no nurse, nobody else has come to us and said, what do you as patients think about your disease? What do you want to know? And that was really a powerful thing for me to hear, to know that no one else even knows you guys are here or is interested in contacting you and seeing what you think about your disease. So that lit a fire in me, and that's why we're doing all this. The next phase of our research is now we've gotten approval to enroll. Anyone who wants to sign up, you can just send me a message and I'll get you signed up. We're going to make a registry where we actually add patients, and eventually we'll get your samples, your slides sent to us, and we'll review them to make sure it really is DFSP. So you can confirm, because sometimes it's misdiagnosed, sometimes they think it's DFSP and it's actually something else. So we want to make sure that we really have true DFSP patients. And then what we'll do is we'll find out information about how big your tumor was, how it was treated. Did you get radiation? Did you get treated with Gleevec, the drug that sometimes is used for DFSP? And then we'll follow up at 5, 10, and even 15 years. And if you ever want to drop out of the study, you can. You're not required to be in it. But the goal will be to find out, not just from a little small number of patients, but from a huge number of patients from all over the world that are treated a lot of different ways, what influences the risk of getting a recurrence or not, the risk of getting a metastasis or not. And we're going to try to answer those questions because we don't have good answers to that right now. And hopefully with a bigger number and longer follow-up, we'll be able to do it. So it'll take a long time, but really the only cost is just the shipping of having your slides sent over to the US. We'll take a look at them. We may occasionally have to run an extra test to confirm it. We'll send it back when we're done. And the shipping is not that expensive, but if we get 500 patients or 1,000 patients to sign up, well, it adds up a little bit. But other than that, it's just my time, Margie's time. All of us will just work and we'll put it together and we'll try to get real answers. Again, it may take some time to get those answers, but this group is the most powerful way to do it. So that's the goal, and that's what my vision is for the future of DFSP research. And one other thing that I've kind of come to realize through all of this is that my career goal, my life goal, which if you asked me 3 years ago, I would have never thought of this. But at the end of my career, if I can look back and say we've accomplished this during my time in medicine, I'll be happy. Is that every rare disease, every sarcoma, every type of rare disease needs to have a patient support group, ideally on Facebook, I think, because it's the best way to do it. And then each of those groups should have a pathologist and other types of doctors involved in the group with the leaders of the group working as a partnership, because who better to be able to answer those questions than experts who are actually interested and know about that disease? And who better to help teach and inform those experts than a group of patients who actually have the disease? And if you're looking for people to promote, and that's what I tell when I talk to other doctors, I said, if you want people to promote your research and to go out there and share the word about it and to raise money for you to help get it done, who's going to do that more than a group of patients who have the tumor or who have that disease? Because they are the most interested in finding a cure, finding answers because they have it, or their kid has it, or their family member has it. So I think it's a great partnership, and I would love to see every rare disease have this kind of partnership like you have here, that can bring people together from all over the place to come and meet and have English cream tea in South England and talk about DFSP, right? I mean, that wouldn't have happened without Pitt making this group on Facebook. And I thought every disease deserves this opportunity. And every pathologist, I think I know a lot of pathologists and other doctors who would like to contribute, they just don't know how. So I've thought about that a lot, and it just occurred to me actually on this trip after I gave my lecture last week, what I want to do, and I'm going to tell you first, this is the first time I'm telling this, but I thought this all started with you in this group, so I want to start a coalition of pathologists and patient support groups and bring in the heads of different patient support groups from sarcomas, other rare diseases, and kind of have a dating matching service, so to speak, where a group says, hey, we want a pathologist involved that knows about Langerhans histiocytosis. And I say, okay, we'll go and find someone and see who wants to be involved, and we'll plug them in with you. And I think that by matching, I think it just takes someone to have the infrastructure to match up the right person with the right group, and then it will naturally kind of happen just like it did here. And so I have that experience because I've been doing this and working with groups, and I like to push the boundaries and push the envelopes of what people think it should be done. So I think that this would be a nice thing. So I'm going to try to make that kind of a coalition. I'm going to make a group on Facebook with that intent of kind of matching up doctors who have expertise and interest in helping patients with that disease and support groups who are looking for doctors to partner with. So that's because of all of you guys. This experience has really made that much of an impact on me that I thought, this is what I want. I don't care how many papers I publish in my lifetime or what rank I get promoted to. I care about seeing this happen because this will help people in real life who are suffering. That's why I do medicine, because I want to help sick people. Is it done?
No, it's good.
Oh, okay. So that's my plan so far. I think at that point, I will answer whatever questions you have for me.
Well, we have over 30 comments, so I'll just work through them.
Okay.
How similar to other sarcomas is DFSP, and what quantifies DFSP to be a sarcoma?
Okay, so the question is, how similar is DFSP to other sarcomas, and what's the qualifying factor that makes DFSP actually a sarcoma? So sarcomas are malignant tumors of connective tissue, meaning like your fibrous tissue, fatty tissue, muscles, veins and arteries, nerves, all of those types of tissue can give rise to different rare cancers that are called sarcomas. So sarcomas are tumors that are malignant that come from that kind of tissue and then can spread to other parts of the body and potentially be aggressive. DFSP only rarely spreads, and so sometimes people tend to think, well, it's not really a cancer. But as you all know, it can be locally pretty aggressive. It can grow back multiple times and cause problems there, and it can rarely spread to other parts of the body. So because of that, it would qualify, in my view, and in the view of most other authorities, as a cancer, and therefore it would be a sarcoma. So it is technically a sarcoma. Now, as far as how similar it is to other types of sarcomas, that's a little bit more complicated because there are over 100 types of sarcoma, many of which are very different from each other. And I would say that DFSP is actually quite different from most other sarcomas because it has a high risk of growing back if you don't treat it and get all of the tumor out, but it has a relatively low risk of spreading elsewhere in the body. So most other sarcomas are not that way. Most of the other sarcomas have a higher risk of spreading elsewhere in the body, and the risk of locally growing back is not quite as big of a concern. I mean, it is a concern, but it's not as much. So DFSP is very unique. You really are unicorns, as you call yourselves, in many ways, because it's a very unique and unusual type of tumor that's quite different. It's not truly a skin cancer, even though it occurs in the skin. It's a sarcoma. It's different than other types of skin cancer, and I think the danger in calling it a skin cancer is that people will regard it like basal cell carcinoma or squamous cell carcinoma, common skin cancers, which is definitely not like. So I think it really is a sarcoma, but it's very different from other sarcomas.
How common is it for more than one person in a family to be diagnosed with DFSP? I don't know if we know that yet, do we?
Good question. So the next question is, how common is it for more than one person in a family to be diagnosed with DFSP? And I would say it's extremely, extremely rare. I've never personally seen a case where two family members both had DFSP. For two family members to even have sarcoma of any sort is really rare because all sarcomas are very uncommon. But to my knowledge, I've never personally seen a case that I've verified with my own eyes. I've heard of rare reports from the group. One person maybe had mentioned, yeah. But it's basically, as far as we know, it's not a genetic link for DFSP to occur. So for two people in a family to get it would be extremely rare because just the odds of one person getting it are so low. So if you put two of those, two unicorns in the same family would be pretty rare, right? So it's extremely unlikely, but theoretically it could occur.
What would likely be the cause of METs from DFSP? Because as we discussed earlier, we know that I actively had DFSP for at least 14 years, yet thankfully I have no METs, I didn't get any METs. So what predisposes someone else who has DFSP maybe to get METs, in a shorter time period?
That's a good question. So the next question is what causes someone to get metastasis, where DFSP spreads to another part of the body? That's a question that we ask ourselves with all cancers. Why do some cancers metastasize and spread, and those are the cancers that potentially cause death, and other cancers not? Or why does, the same type of cancer, why does one spread and the other not spread? And so we spend a lot of time in medicine trying to sort that out because that's hugely important. That's what really is going to change the life of the patient more than anything else, is the chance of it spreading somewhere else to the other parts of the body. DFSP, it only rarely happens that it spreads. I've seen one or maybe two cases personally in practice that have ever spread. And the one that I can recall was one that the patient had for many, many years. It had grown back multiple times and it spread. So kind of like Pip's situation. But maybe it's just that you got lucky. Maybe it's that even out of the people that have had it for years and multiple recurrences, even then it's still only a small group that actually get spread. But as far as what causes one to spread and the other not to, I think that we really just don't know yet. In other types of high-grade sarcomas that are rapidly growing, which DFSP is not really usually, they tend to spread quickly because they have rapid growth and they grow quickly and they invade blood vessels and then spread to the lungs and other parts of the body. But DFSP is not like that. Again, it's very different and very unique from other types of cancer and other types of sarcoma. So I think we don't know yet, but maybe our study will answer that. It may be sometime, but maybe down the road our research will shed light on that.
Okay. So if the 1722 gene translocation is considered a random or an unlucky event, then how can you explain unicorns that have multiple DFSP locations? Are they individual multiple locations, or are they METs from an original tumour site?
That is a great and difficult question. So
Sorry.
no, that's good. This is
That was one of mine.
this is how we learn. It's a good question. So Pip's question is the 1722 translocation that involves the collagen 1A1 and PDGFB genes. If that gene happens or fusion happens randomly, if someone gets to different DFSPs at different sites in their body, is that a spread from the tumor from one site to the other, or is that just a new primary tumor? That's a really hard question, and whenever we see a patient with two places with cancer of the same type, we have to ask ourselves that. Is this spread from one place to another, or is this a new primary tumor that's popped up totally independently of the other? And that's a big difference because of the way we stage patients with other types of tumors. We look at that, and we always have to ask that question because it usually, if the tumor is spread somewhere else, that's usually much more problematic because that means the patient may get more tumors down the road. So sometimes there's no perfect way to answer that. We don't know, and what we have to do usually is scan the whole person if we see a situation like that. Scan them, see if they have nodules anywhere else. If they start getting multiple nodules, then that's a sign that the tumor is probably spreading. If they just have two and they down the road are still doing well several years down the road, then that's a sign that maybe these two are unrelated. I've personally never seen a single patient with more than one DFSP. There are a couple people in the group that have reported that, but that would be so unusual to me and so rare that I would have to see that under the microscope with my own eyes. I'm sure it can happen, but it would be extremely exquisitely rare. So. And certainly, something that's case reportable. So hopefully we'll capture that when we do our research study, be able to include that and learn more about it.
It's like a leprechaun riding a unicorn.
Yes.
Right.
Yes. Exactly.
In a kilt.
In a
Just
kilt.
to spell it
Of
in.
course, right.
Do you know if there may be any links between thyroid cancer and DFSP?
Okay. Are there any links between thyroid cancer and DFSP? None to my knowledge. I would think that there would probably not be because thyroid cancer, the genetic problems that cause thyroid cancers, at least the ones we know about, are different genes and different DNA problems than the ones that cause DFSP. So I would think that there would not probably be any relationship, and there's none that I'm aware of.
What are the chances of recurrence after the 5-10 year mark? That's the question, but could I ask if you can explain our theory about recurrence as opposed to
Sure.
a continuation of?
Yeah. So when we talk about local recurrence or a tumor growing back after it's been surgically removed, we say recurrence, but what that really means is that actually there was a little bit of tumor that was probably left there at surgery. And no matter how careful we are at looking at all the margins, it's impossible for us to see the entire margin perfectly. There's different, that's a kind of a longer, complicated topic. We do the best that we can to see all of it, but it's always possible that even if the margins look negative, a little bit of tumor got left behind. The chances are, though, that when you have a nice wide normal margin, the chance of having recurrence is much lower. If you had a really close margin or a positive margin, the chance is higher. But recurrence just means that there's a little bit of tumor that was left that is now growing back and getting larger over time. I would say after 5 or 10 years of no recurrence, and especially if you have free margins, the chance of recurrence at that point is probably quite low. It could theoretically happen. You could have a late recurrence after that time, but it's uncommon, I would say, in my experience. But there are always exceptions to the rule.
Okay. A member of my extended family recently had surgery for PVNS. Like DFSP, prior to the diagnosis, I'd not heard of it, but now see both are treated by the same doctors in some cases. Any thoughts as to why? What do the two have in common?
So PVNS is known as pigmented villonodular synovitis. It's the other name for it is the diffuse type of tenosynovial giant cell tumor. It's not related to DFSP at all. The reason that the same kind, my doctors that treat DFSP that are orthopedic oncologists, they're orthopedic surgeons that specialize in bone and soft tissue tumors. So their PVNS usually occurs in the joints, like the knee is the most common site in the knee joint. So those kinds of doctors are the kinds of doctor that would operate on a tumor of the bone or of the joint. And they're the same kinds of doctors that have experience in operating on DFSP. So that's why the same doctor, they're not really related otherwise. But PVNS is somewhat similar in that it can be locally aggressive, but it does not metastasize. And it can cause problems locally by growing into the joint. It can cause the joint to freeze up. But it's totally unrelated. Microscopically looks nothing like DFSP, but that's why the same doctors treat it, just because they have that expertise of that kind of surgery.
Why is there no other way of checking for recurrence before actually feeling or seeing it? Why do most doctors do such minimal checks at the yearly check i.e. just a visual check and a feel around the site, why isn't a CT scan mandatory?
Okay, so the question, why do we not have a better way to detect recurrences? You know, if you go back after your surgery, the doctor might feel for a bump and say, well, I don't feel anything, it looks okay. Let's come back later and we'll get checked again. Why don't we necessarily have scans, like a CT scan of the site? Why don't we have a better way to detect this? Well, that's a good question, actually. And I would say that the problem is that when DFSP recurs, if it recurs and it's so small that you can't feel it yet, the chance of being able to see it on a scan in the middle of a bunch of scar tissue is probably pretty low. I'm not a radiologist, but I do have some experience looking at radiographs and CTs and MRIs, and I know a lot of radiologists who specialize in sarcoma radiology. And I think that the chance of being able to see it when it's that small that you can't even feel it is pretty low. And so the other thing is that MRI does not cause radiation to your body, but CT scan is X-ray. Basically, it's actually a lot of X-rays being done in a circle around your body, and then a computer puts that together to make an image. And even though the risk of that radiation causing a problem is relatively low, to have scans done again and again and again when there's not a proven benefit to them is, you know, you're giving someone a risk, even if it's a small amount of risk, that radiation could potentially cause problems. Now, again, if someone told me that I needed to have scans, I would get scans done. But if it were me with DFSP, I probably would personally choose to, after the tumor was removed, to just have it checked and just to watch for lumps and probably not have scans if it was me personally or my family member. Now, that if your doctor recommends something different, that's okay. And I don't know that there's necessarily a right or wrong answer here. There's just different ideas about it. And again, this is hopefully something that our study will be able to look at. And we actually do have some ideas, and I can't go into it yet because we're not sure if it will work, and also we don't want anyone else to steal the idea. But we have some ideas for potentially blood tests to be able to try to see if we can detect recurrence earlier. We're not sure if it will work yet, but Margie David actually came up with a really brilliant idea, and we're going to try to test it out as part of our study and see if we can maybe find something that will answer this question and get us an earlier answer.